Welcome to this Step 3 review on shock states, brought to you by Roadmap to Residency. Shock questions feel scary, but they follow a tight set of patterns, and once you see the patterns, they become some of the most predictable points on the exam. Our goal today is not to reteach all of critical care. It is to show you how shock vignettes are built and how to attack them fast. We will classify every patient into one of 4 buckets. Read the bedside and the monitoring numbers as clues, and match volume, vasopressors, and inotropes to the specific problem. Keep your question bank and a solid critical care review resource open beside this video, because these patterns stick best when you drill them. Let us get started. Here is what we are going to cover today. First, we will learn to classify every shock patient into one of 4 buckets: distributive, cardiogenic, hypovolemic, or obstructive, by reading the bedside picture before we read the answer choices. Second, we will turn hemodynamic monitoring numbers into a fast diagnosis using preload, the pump, and afterload. Third, we will match the treatment to the bucket, deciding when to give volume, when to reach for a vasopressor, like norepinephrine, and when to add an inotrope like dobutamine. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to classify the shock before you treat it. The fastest way to do that is to read the skin and the pulse pressure, both of which the question almost always hands you. Warm, flushed skin with a bounding, wide pulse pressure points you toward distributive shock, the kind you see in sepsis. Cold, clammy skin with a narrow pulse pressure points toward a pump or volume problem, meaning cardiogenic or hypovolemic shock. Decide warm versus cold before you even look at the options. Then sort the patient into one of 4 buckets: distributive, cardiogenic, hypovolemic, or obstructive. Naming the bucket is the whole game, because the correct management usually follows automatically, and the wrong answers are almost always the right treatment for the wrong bucket. Sort first, and the trap choices lose their power. Strategy 2 is the hemodynamic number grid, and this is what saves you when a question buries you in invasive numbers. Anchor on just 3 values. The central venous or filling pressure reflects preload, meaning how full the tank is. The cardiac output reflects the pump. The systemic vascular resistance reflects afterload, meaning how tight the vessels are. Read each one as simply high or low, and let the pattern name the shock. Distributive shock shows high output with low resistance. Cardiogenic shock shows low output with high resistance and high filling pressures because the pump is failing and backing up. Hypovolemic shock shows low output with high resistance but low filling pressures because the tank is empty. Obstructive shock shows low output with high resistance, usually with a specific physical clue pointing to a mechanical block. Match the grid and the diagnosis falls right out. Strategy 3 is matching treatment to the bucket using volume, vasopressors, and inotropes. First, fill the tank in most shock. For distributive, hypovolemic, and most early shock, intravenous fluids come before any pressor. So if the stem has not yet given adequate fluid, more volume is usually the next best step. The big exception is cardiogenic shock in a patient who is already flooded, where aggressive fluids are the trap, and you support the failing pump instead. Second, pick the pressor that fixes the defect. Norepinephrine is the default first-line vasopressor for septic and most undifferentiated shock because it raises resistance with little extra heart rate, while an inotrope like dobutamine is for a weak pump. Low resistance calls for a vasoconstrictor. A failing pump calls for an inotrope. Third, beware obstructive shock, where no amount of fluid or pressor fixes the problem. Attention pneumothorax needs decompression, a tamponade needs drainage, and a massive pulmonary embolism needs the clot addressed. If the stem points to obstruction, the answer is the procedure, not another bag of fluid. Let us work through our first practice question, and this one tests distributive shock. A 70-year-old man is admitted with fever and a urinary tract infection. His blood pressure is 80/40, his heart rate is high, and his skin is warm and flushed. He has already received 2 liters of intravenous crystalloid, yet his mean arterial pressure stays low. Blood cultures are drawn and broad antibiotics are started. The question asks for the most appropriate next step. Notice the warm skin, the clear source of infection, and the crucial detail that he has already gotten adequate fluids and is still hypotensive. Read the 4 options carefully and pick your answer, then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. Fever, a clear infection, warm flushed skin, and a wide pulse pressure all scream distributive shock from sepsis. The key detail is that he has already received 2 liters of fluid and remains hypotensive, so the tank is full, but the vessels are too dilated. This is fluid refractory septic shock. Second, apply the rule. The defect in distributive shock is low systemic vascular resistance, so the fix is a vasoconstrictor. Once a septic patient stays hypotensive despite adequate fluids, the next best step is to start norepinephrine, the first-line vasopressor in septic shock. Third, eliminate the wrong answers. Dobutamine is an inotrope for a failing pump, which is the wrong defect here. Hydrocortisone is added only after a patient is already on pressors and stays refractory, so it is not the next step. Transfusion treats blood loss, and nothing here suggests hemorrhage. Each distractor is the right drug for a different shock. The correct answer is to start an intravenous norepinephrine infusion. Here is our second practice question, and this one tests cardiogenic shock. A 65-year-old man is in the hospital one day after a large anterior myocardial infarction. His blood pressure is 80/50 and his heart rate is high. His skin is cool and mottled, his neck veins are distended, and he has crackles throughout both lungs. A bedside study shows a severely weakened, poorly contracting heart. The question asks for the most appropriate next step. Notice the cold skin, the recent heart attack, and the signs that the tank is already overfilled, namely the distended neck veins and the wet lungs. That combination should steer you away from more fluid. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, spot the flooded pump. A recent large heart attack, cold mottled skin, distended neck veins, lung crackles, and a weak squeezing heart together describe cardiogenic shock. The full neck veins and wet lungs tell you the tank is already overfilled, so the defect is the pump itself, not the volume and not the vessel tone. Second, understand why fluids are the trap. The correct move is to support the failing pump with an inotrope such as dobutamine and to push toward fixing the underlying cause with revascularization. Rapidly infusing saline floods an already wet patient and is the overkill trap. A beta blocker further weakens an already failing contraction and can be deadly here. A diuretic alone may dry the lungs but does nothing to raise the dangerously low cardiac output. The correct answer is to start dobutamine and arrange revascularization. Let us talk about reading Hemodynamic Monitoring, because when a vignette dumps invasive numbers on you, that is a gift, not a threat. First, turn the numbers into a diagnosis. Read the filling pressure, the cardiac output, and the systemic vascular resistance together as a set. Low filling pressure with low output points to hypovolemic shock, an empty tank. High filling pressure with low output points to cardiogenic shock, a failing pump backing up. High output with low resistance points to distributive shock, wide open vessels. Let the numbers, not your gut, name the bucket. Second, let the target pick the next step. Monitoring also tells you whether your treatment is working, so a rising mean arterial pressure and improving urine output mean you are on the right track. If a question asks what to do after a number changes, trace that change back to preload, the pump, or afterload, then choose the intervention that corrects whichever one is still off. The trend in the numbers is the clue the writer wants you to follow. Here is our third practice question, and it tests obstructive shock. A 25-year-old man arrives after a car crash with a seatbelt injury to the chest. His blood pressure is 70/40 and his heart rate is very high. His neck veins are distended, his trachea is shifted to one side, and breath sounds are absent over the right chest, which is hyperresonant to percussion. He is in severe respiratory distress. The question asks for the most appropriate next step. Notice the trauma, the shifted trachea, the absent breath sounds, and the distended neck veins, all pointing to a mechanical block rather than a volume or vessel problem. Be very careful with any option that delays treatment. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, let the physical exam give it away. Chest trauma, distended neck veins, a trachea pushed to the opposite side, and absent breath sounds with a hyperresonant chest are the classic picture of a tension pneumothorax. Air trapped under pressure is squeezing the great veins and blocking blood return to the heart, so this is obstructive shock, where the mechanical block, not volume or vessel tone, is the killer. Second, treat before you image. Tension pneumothorax is a clinical diagnosis that demands immediate needle decompression. Fluids and pressors cannot overcome the mechanical block, so they only waste precious time. The most dangerous distractor here is ordering a chest radiograph first, because stopping to confirm with imaging delays a life-saving procedure in an unstable patient. The correct answer is immediate needle decompression of the chest. Here is a critical exam day pearl that ties everything together, the warm versus cold shortcut. When a shock stem overwhelms you, fall back on one fast question. Is the patient warm or cold? Warm skin with a wide pulse pressure means distributive shock, so think infection and reach for a vasoconstrictor. Cold, clammy skin means a pump or volume problem, so think cardiogenic or hypovolemic shock. That single split sorts most vignettes in seconds. Once the bucket is set, ask a second question. What is this patient missing? And give exactly that. An empty tank needs volume. A weak pump needs an inotrope. Dilated vessels need a vasoconstrictor. A mechanical block needs a procedure. Replace only the missing piece and you will sidestep the trap of treating the wrong defect, which is exactly where most wrong answers live. Warm or cold, then what is missing? 2 questions, and most shock points are yours. That wraps up our review of shock states for Step 3. Remember the core moves we covered today. Classify every patient into one of 4 buckets: distributive, cardiogenic, hypovolemic, or obstructive, by reading the skin and the pulse pressure first. Use the hemodynamic numbers, the filling pressure, the cardiac output, and the resistance as the clue that names the shock. Then match the treatment to the defect, choosing volume, a vasopressor like norepinephrine, an inotrope like dobutamine, or a procedure for a mechanical block. When in doubt, ask warm or cold, then ask what is missing. The best way to lock all of this in is to drill shock questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.